her. They're my son that lives in Charlottesville, Virginia. And I was a little concerned coming because she had some separation anxiety. And so the first night they were here, we went out to eat. And my son assured me that Edie would be fine, just to put her in the bonus room and she would be fine. Well, we did. And on the right shows what she did to the bonus room, trying to get out the window to find us or her dad. But she's a little rescue beagle mix that they got in Charlottesville. But Edie hadn't been back to our house since, and I'm not sure that we'll let her, but I'm teasing. She's welcome because subsequent to this visit, she did do a doggy obedience school, and she passed. There's her certificate of achievement, that all things pausable basic obedience class. So she's doing better now, so she might be able to come back and see us. Okay, let's get started with the real stuff here. If you look at the last few years of FDA approval of new drugs, you see 30, 39, 27. The last 3 years, it's been 59, 48, and last year was 53 new drugs. And when I look at this, I always take solace in the fact that there's always going to be a need for folks like me to teach because every year we've got 40 or 50 new drugs coming out, and we still use the ones that we've got. Now let's break down further this 53. Of the 53 agents approved in 2020, and as I said, the historical average of 10 years is about 40. The most ever is 62 back in the mid-90s. But of those 53, 31 were what we call orphan drugs. Now, you may or may not have heard that term, but those are drugs so classified because they're really kind of orphans in that if it would be a very low number of people who would ever have a need for those. And they're for rare diseases kind of thing that most of you are not going to hear of any of those 31 drugs. I don't know any of them that were focused towards women's health here. So more than half of the drugs you'll probably never even see or hear. 21 of those 53 were what we call first in class, a new class, a new way of doing things, as opposed to a new beta blocker, a new ACE inhibitor, those kinds of things. 17 of these were fast-tracked. That means that they were expedited through the process to get them onto the market, particularly those first-in-class drugs or some of the orphan drugs that are widely needed. 22 were considered breakthrough. That's FDA's designation that basically says these are likely to be very, very useful, high-selling, highly prescribed drugs. 30 of those received priority review. So again, more than half were prioritized to get them through the system, and 12 had what we call accelerated approval. So those are, you see the trend here is to get things done and get things done fast. Well, 2020 also brought about, renewed our interest in what's called emergency use authorization. If you look at the bottom line on that slide, the COVID issue, and we'll talk a little more about that at the end of the slides today. But to get a vaccine on the market in a year was just unheard of. Normally it takes 4, 5, 6 years to get a vaccine on the market. So make sure you understand, though, emergency use authorization is not full FDA approval. That just means that FDA has reviewed it and consider them safe and effective, and we'll go ahead and get them on the market without finalizing all the X's and O's. Things are tested the same. It's just a matter of the paperwork and things to get them final approved is expedited. So you ask yourself the question I've asked there, is this a good or a bad thing? And as I said, over the last 40 years, the FDA has really loosened some of the requirements, increasingly accepting less data, more what we call surrogate endpoints in clinical trials, shortening reviews. They are accepting now foreign data that can be extrapolated to the United States, et cetera. if you go back to the mid-90s, over 80% of the drugs were approved on 2 pivotal trials. That number dropped to just over 50% in 2015 to 17. And again, a number of programs were enacted that we just talked about, the breakthrough, the expedited approval and fast track, et cetera, has really changed that. We could have a debate about good or bad, but it does get drugs on the market quicker. But from the other side of the coin, it does mean that drugs have not been tested as much as we normally would, which again could be good or bad, but what it does, I think, to physicians, pharmacists, nurse practitioners, nurses, is it creates the need for us to be more vigilant in reporting and monitoring side effects, efficacy, et cetera, from these drugs. If something occurred 1 in 10,000 patients, and they studied 8,000 patients, then statistically that wouldn't show up. But once 1 million people have used it, suddenly you've got 100 cases of that 1 in 10,000 kind of thing. So it's something to keep in mind. It is what it is, but that's what FDA is doing. Now let's start off the contraception section here with kind of a pre-test to test your knowledge on 3 questions about contraception. And this was actually done, placed on medscape.com. And once you answer the question in your mind, I will go to the next slide and show you what % of the people who took that test on Medscape gave for their answer. We'll see if you're smarter than the average person taking the test. So the first question, which of the following is the most accurate regarding recommendations for contraceptive use by the CDC? And this is not ACOG, this is CDC recommendations. If you think A is the most accurate, then you put A and B. So let's go through these. If progestin-only pills are started more than 5 days after menstrual bleeding started, women should abstain from sexual intercourse or use an additional contraceptive method for the next 2 days. B, misoprostol or Cytotec is recommended for routine use before IUD insertion. C, a pelvic exam and screening for obesity is recommended prior to the insertion of the endometriosis or implanon implant. And D, women who are breastfeeding can begin using combined hormonal contraceptives 7 to 10 days after delivery. Okay, let's get an answer in your mind that you think is right. And then we will go to the next slide. And 47% of those taking the test got this right according to Medscape. And that answer is A. Progestin-only pills started more than 5 days. Women should abstain from sexual intercourse or use an additional method for the next 2 days. 6% said that misoprostol was recommended for before IUD insertion. 35% said you should do a pelvic exam and screening for obesity for the implanon, and 12% said that breastfeeding can begin 7 to 10 days after delivery. So let's look at this a little more, some rationale. The correct answer is A, and according to CDC guidelines, if progestin-only pills are started within the first 5 days since menstrual bleeding started, no additional contraception protection is needed. Started more than 5 days, women should abstain from sexual intercourse or use additional contraceptive method for 2 days. CDC does not recommend routine use of misoprostol. I do remember 3 or 4 years ago, this was a question that was brought up and I think addressed at this meeting with your group. Pelvic exam is not necessary before the implanon. Obese people can use these, and so screening is not required for this. Now, it does need to be a consideration for oral contraceptives, but not for the implanon. And then the women with breastfeeding it should not use these the first 3 weeks. Concerns about VTE, blood clots, et cetera, and avoid the combination oral contraceptive in the 4th week because of concerns about the effects on the breastfeeding performance. Okay, the next one's not quite as long. Oral contraceptive use decreases the risk for which of the following conditions: migraines, hypertension, blood clots, or pelvic inflammatory disease, PID. So get your answer in your head, and we'll see if you are correct. 39% said migraine headaches, 7% said high blood pressure, 4% blood clots, and half the folks said PID, and that is correct. We'll talk more about migraine headaches in just a little bit, but the use of oral contraceptives, you know, have a lot of non-contraceptive benefits. Prevent benign breast disease, PID, functional cysts, lessen the epithelial ovarian endometrial carcinoma. Particularly those that have estrogen can trigger migraine headaches. And some have also been associated with risk for blood pressure, high blood pressure, et cetera. Again, getting back to headaches, you'll see some women taking these to prevent migraine headaches. And that's some part of an oxymoron, but in some cases, they do work for that. But CDC says they can trigger migraine, particularly based on whether you have an aura or not an aura before your migraines. But I don't want to get too involved with that because that's another lecture into itself. The risk on blood pressure migraine may be an increase in the renin substrate in certain susceptible individuals. Risk is higher for patients that are obese, that have a family history or a personal history of smoking, and women with high blood pressure probably should use a progestin only. And then the last rationale for that question, oral contraceptives increase the risk for blood clot, DVT in the legs. Estrogen, as you know, it activates the blood clotting mechanism. All right, the third and last one. Which of the following is the most accurate according to the guidelines on emergency contraception from ACOG? This is different from CDC, maybe. First, A, levonorgestrel emergency contraception should be avoided in women who wish to later become pregnant due to an increased risk for subsequent ectopic pregnancy. B, oral emergency contraceptive may be used more than once, even within the same menstrual cycle. C, a pregnancy test is recommended prior to administration of emergency contraception to avoid unnecessary use. And D, most emergency contraceptives are ineffective 48 hours after sexual intercourse and should only be offered within 72 hours. So get your answer to that one, and hopefully we'll see if you can go 3 out of 3. Correct answer there, the most accurate, is B, oral emergency contraceptive may be used more than once, even within the same menstrual cycle. Now, interestingly, only 37% got that right. If you look down at D, that got 49%. Most emergency contraceptives are ineffective 48 hours after sexual intercourse, and they only be offered for 72 hours. So let's look at the rationale for this question. According to ACOG, we just don't have data available on the safety of current regimens of emergency contraception if used frequently over a long period. However, most oral emergency contraceptive may be used more than once, even within the same menstrual cycle. Treatment should be initiated as soon as possible after intercourse to maximize efficacy, of course, and then emergency contraception should be made available to patients who request it as long as 5 days after sexual intercourse. Now, we'll talk in a minute about Ella, which I understand is now on the formulary, which is approved for 5 days, but even the others may still be effective up to 5 days. Now, well, let me go back to that point about emergency contraception may be used more than once. About 3 years ago, Prescribers Letter reviewed this issue, and I love their rationale, their answer. They said it's not very smart to do that, to use it more frequently, and it costs a lot of money, but it's not dangerous to use. So it's not recommended that you do, but it can be done. ACOG also indicated that existing data suggests that levonorgestrel emergency contraception does not increase the chance of ectopic pregnancy, ACOG also said there's no clinical exam or pregnancy testing before provision or prescription of emergency contraception. Okay, hopefully you did 3 out of 3. This slide is one that my nephew sent me. He's an engineer who is responsible for quality control at the Mars candy factory in Athens, Tennessee. That's where all the M&Ms that you get down there in Alabama come from, is Athens, Tennessee, just north of Chattanooga. Anyway, he's responsible for quality control. So this is a good quality control example. Lady called the bakery and she said, I want 2 birthday cakes and I want you to put happy birthday on both. And so that's exactly what the bakery did. They wrote happy birthday on both. I'm not sure that's what she meant or what it intended, and maybe they should have had a better grasp on what she was asking. But anyway, that's an example of kind of a mistake that should not have happened. Okay, let's move on to contraception and some of the recent developments. Beth sent me a listing of things that you've added to the formulary or using in questions, and I tried to address all those as we go through. I don't want to spend a lot of time on selecting the right contraception for the associated medical condition that your patient may have, because that could take an hour just to go through all of that. You are familiar with this. CDC updates their medical eligibility criteria for contraceptive use. That gives you 4 categories. Category 1 said there's no restrictions. Category 4 says absolutely don't use them, they're unacceptable. Rather than go through specific things, here are the 2 websites that you can put on your phone. If you have an iPhone, the iTunes Apple site is listed there. And if you have a Pixel or Google or Android phone, there's the website for that. If you just Google contraception for conditions, etc., that should come up. They include all of these. I'm not going to mention all these, the specifics, but they look at VTE risk, any thrombus, SLE, migraine, with or without aura, and again, that makes a difference. High blood pressure, diabetes, obesity, depression, breast cancer or family history, particularly the BRCA1 or 2 mutations, personal history of breast cancer, concomitant use of medications like rifampin and liver enzyme-inducing anti-epileptic and antiviral, retroviral medications. Again, that's another whole talk on drug interactions. But rifampin and some of these analeptics increase the metabolism, which is going to decrease the efficacy of those. And then older age, perimenopausal, bariatric surgery, obesity, all those things are talked about on the CDC website for those 2 things. I always like to mention, of course, you do this every day, but there's more benefits to contraceptives than just preventing pregnancy. And you know all of these, but it's nice to be reminded to help patients understand that yeah, there are some risks with birth control pills, but the benefits far outweigh the risk, if nothing else, than preventing pregnancy, but also prevent all these other things. Menageria, we'll talk more about that in a moment, dysmenorrhea, endometriosis, amenorrhea, menstrual cycle regularity, PMS or PMDD, ovarian cysts, menstrual migraines, again without an aura, chemoprevention of ovarian or colorectal cancer, and then treatment of acne, hirsutism. There's, I think, 3 different oral contraceptives that are FDA approved for acne. So they do have a lot of other things, as you know. One other recent thing that came out is they may curb severe asthma attacks. This was published in the journal Thorax, and you can just Google if you want Thorax, oral contraceptives and asthma, and it will give you the original data. But this study of 80,000 women, this was done, I think, in Europe, but a small but significant reduction in severe asthma attacks in those who had been on the pill 3 or more years. Now, when you Google that, You'll also find reports where oral contraceptives may worsen asthma. So that's another reason I put this study in there, is that for most studies on any drug, for any condition, you have conflicting data. And that's why it's very important that we learn to examine studies, look at the inclusion criteria, the endpoints, and all of these things, because studies are just that. They're studies, and they are subjective to different opinions and interpretations. Now, this aspect of birth control pills has been talked about for years. ACOG says they should be over the counter, particularly when you know that some of the emergency contraceptives that contain 5 times the amount of drug are over the counter. And then now several states, 13 states as of a couple of years ago, allow pharmacists to dispense hormonal contraception without a doctor visit or nurse practitioner or approval. There's a lot of online services now that you've seen advertised on television. I'm sure you've been asked about them. If you look at the worldwide restrictions, fewer than a third, about 30% of countries require prescription to obtain these. So it's been, ACOG has called for this since 2019, not just pills, but vaginal rings, Depo, Provenza, and all of these. They also oppose age restrictions once a girl has started menstruation. So I think you'll see more and more of this, and I really think they'll become over the counter. But right now, the only thing the FDA is really looking at is COVID-related things. But that may play a role. I think you're probably going to see an increase in birth rates from COVID, but that's another talk in itself too. Now, a few things that Beth sent me. She said that you're now using Antiviral, or at least a question about the cost of Antiviral, the new vaginal ring. This was approved a couple of years ago. It contains a different drug than it's progesterone acetate and as a progesterone. It's a synthetic estrogen, and then 13 mics of ethinyl estradiol. It is the first product to contain this progesterone, and it's the second vaginal ring behind NuvaRing. NuvaRing gives you etonogestrel with ethinyl estradiol. One of the claims for this is it's softer and more pliable than NuvaRing. I think that would become a personal opinion. The biggest difference is NuvaRing requires a new ring each month, 21 days. The Antiviral is left in place for the 21 days and then removed for 7 days in each cycle, and then it's reused up to 13 cycles. So it's 1 year instead of 1 month. Pearl doesn't work. The Pearl index is 2.98. That's almost three unintended pregnancies per 100 women. Most of the Pearl index of about 80 in couples not using a contraceptive method, and that 2.98 is pretty comparable to most available hormonal contraceptives. So yes, it does work even after the 11th and 12th use. But I think Beth's question was the cost. If you look at the retail price, it's a little over $2,000, $23.35. Some of these discounted coupon places, GoodRx is one, is around $19.81 for a year. Now, if you look at NuvaRing, it's about $519 for 3 rings. So you multiply that $519 by 4, and that's $2,076, which is about the same price as the Antiviral. So it's 6 of one, half a dozen of the other, basically. They're all costly. Now, I don't think the Antiviral is probably going to be discounted or available under some special practice. It may be, but that's the difference. One off the topic comment here about GoodRx. you see the advertisements for GoodRx, up to 80% off. And then if you read the fine print, that's 80% off a select number of drugs. Most of the time, the discount's about 5 or 10%. So pharmacists get really frustrated at times when patients come in, oh, I've got a GoodRx, I need 80% off my price. That's only for a few items, not things like this. There is a new progesterone-only contraceptive that contains drospirenone, which you've heard of. That's in Yasmin Dose. It's called Slind. It was approved in 2019 as a mini pill. It contains 4 milligrams of drospirenone, and it's given 24 days rather than 21. And all the other progesterone-only pills contain norethindrone. So this is drospirenone, which is a spironolactone analog. It has anti-mineralocorticoid and anti-androgenic activity. So most the norethindrone and most progestins have some androgenic activity, the masculinizing, hirsutism, etc. This is actually has more estrogenic activity from the progesterone component of this. And the anti-mineralocorticoid part of that is primarily manifested in potassium. And it prevents or decreases potassium excretion. Therefore, you need to watch out for hyperkalemia, which can cause heart rhythm disturbances, etc. We are taught with most potassium-depleting diuretics, Lasix, hydrochlorothiazide, etc., that you've got to supplement potassium. In this case, you need to limit potassium. So certainly don't take potassium chloride, but be careful about fresh fruits, vegetables, etc., that have a lot of potassium in them. Yaz has both drospirenone and the ethinyl estradiol. That's the difference in those. Since Librel is no longer available, we now have Amethyst, which is a levonorgestrel ethinyl estradiol. It's kind of a generic version of Librel, which is used for a year, 365 days a year. You have no periods, you get a new one, etc. It does have a black box warning about use in obesity, BMI greater than or equal to 30. It does cause a higher risk of VTE. So that is a black box warning on Amethyst. Almost all the contraceptives, estrogen or progestin contraceptives, carry a warning about obesity, but not all of them are black box warnings. Now, there are black box warnings on Xulane, the transdermal extended release agent. Women over 35 who smoke should not use this. Cigarette smoking increases the risk of severe cardiovascular events from any of the combination contraceptives. It also has a high risk of VTE if you use them compared to women that have other types of use other types of oral contraceptives. Now, the limitation of use with the Xulane, if you look at the note down at the bottom of the slide, an FDA limitation of use for Xulane is that it may be less effective in pregnancies in women 90 kilograms or greater. Convert that to pounds, it's 2.2 times 90. It's not a black box warning as it is with Amethyst. Now, why? Supposedly, if you go back to the first bullet, the pharmacokinetic profile of ethinyl estradiol for the norelgestrosterone and the ethinyl estradiol transdermal system is different from the oral contraceptives that has a higher area under the curve, time concentration curve, and steady state, lower peak concentrations. This has been discussed for the last 10 years about why the patch is more likely than the pill, and that's the best explanation that I have seen But I think Beth had asked about a black box warning on all transdermal. It's not. It's Xulane. It's a limitation of use. Now, is there a legal difference between a black box warning and a limitation of use? I don't know that it's come up in court, but you still should be careful with that. We got a new patch out, a weekly contraceptive patch called Twirla. It was approved just over a year ago. Again, women whose BMI is less than 30, that's the magic number. It's a transdermal system applied weekly for 3 weeks of the month. You get 30 mics of ethanoestradiol, 120 mics of levonorgestrel a day. What advantage does it offer over Xulane, which is a similar type thing? We don't know, hasn't been determined. Medscape reviewed it last year and said that they don't know of any significant advantage over the drug. It seems to be the same. Now, switching out of drugs, here's an interesting, it still has drugs, if you want to use that word, but not hormonal. It's called Phexi. It's a contraceptive drug comprising lactic acid, citric acid, potassium bitartrate, and it was approved as the first non-hormonal on-demand vaginal pH regulator. Keeps the pH of the vagina around 3.5 to 4.5, and supposedly that serves as a contraceptive. Here's the clinical trial on this. 1,100, little over 1,100 women were intravaginally administered a 5-gram dose in a gel form up to an hour prior to intercourse. I had 101 pregnancies during the 47-69 cycles. The 7-cycle cumulative pregnancy rate was 14%. Again, not as good as oral contraceptives. There are some adverse effects. Change in urinary pH, change in vaginal pH may cause UTI, bacterial vaginosis, discharge, dysuria, some burning sensation, pain, pruritus, some mycotic fungal infections. Interestingly, if you look at all those side effects, it was previously approved as a vaginal lubricant called Amphora, but it was never marketed. They got approval, but didn't market it. And I guess if it causes the burning sensation, all that, that might be a reason, but I don't know how it got through the approval process with that. I told you all I know about it. I don't know if you've seen it, heard about it, or had questions asked about it, but that is available for use 1 hour prior to intercourse. I don't think that's going to be a big seller, but wanted to mention it. And then here's the family circus. What's the magic word to get what you want? Grandma. I would change that in my case to granddaddy for one of my granddaughters, and I'm G-daddy to the other one. The little one calls me G-daddy because she said, I can say granddaddy, but I'm going to call you G-daddy. She just wanted to be different. By the way, I didn't show you pictures this year. I know you get tired of that, but my oldest is a senior in high school. She's off visiting colleges, and et cetera. Can't believe it. My youngest is in the 6th grade. She just turned 12 years old and growing up quick. So anyway, that's kind of a breaking point before we talk about emergency contraception. And let's talk about that for just a minute. We've got several of these on the market and have been on the market for several years. One thing that we have seen is the groups urging for better access to emergency contraception. This came from the American Academy of Pediatrics. They said pediatricians should be aware of emergency contraception methods and should have broader access for these to reduce teen pregnancies. Some of the barriers they mentioned in this publication was cost, about $50. Accessibility, what do you mean accessibility? They're over the counter. Well, 64% of pharmacies in a recent study stock them, so some pharmacies don't even stock them. But half of those 64% kept them on a locked shelf. So you had to ask for them, and that prohibits some things. So there's a lot of barriers to getting access to these things. A couple of developments. There's a new one called Provenza. It was approved in 2018. It's dosed as 1 levonorgestrel, 1.5 milligram, just like Plan B, one step, take action, my way, and all the others. So is it different? No, just has a different name, same issues, etc. Pharmacist letter in 18 said that you should feel comfortable recommending over-the-counter levonorgestrel within 3 days, but then they said it can be used up to 5 days after sex, but labeling doesn't recommend it. And the efficacy does decline the longer the patient waits. But as I said earlier, if it's 3.5 days, it's still probably going to work. But to be sure, you can go with the Ella one. I understand that's been added to the formulary. This has been on the market for about 11 years now. It is a progesterone agonist, antagonist. It's a prescription at this time. It's used up to 120 hours or 5 days following unprotected intercourse or a contraceptive failure. The one thing that this drug did elicit is some response from anti-abortion groups. They said this drug is chemically similar to the so-called French abortion pill, the RU486. FDA has reviewed this, various medical groups have reviewed it, and has said that they found no evidence the drug could terminate an existing pregnancy. But you still have those questions arise, but pharmacologically, medically, it does not terminate an existing pregnancy. It is also used off-label for uterine fibroids and works fairly well for that. Now, if you've had chemistry, which I would assume all of you have, you might get this joke, but if you have not, you might not. Should I tell a sodium joke? Nah, better not. Showed it to my wife, who's an elementary school teacher, didn't have chemistry. She got it. So I would hope that most of you would understand this joke. Okay, a couple of miscellaneous developments in women's health. Endometriosis treatment. This is a very, very acting, disturbing, painful condition, as you know. This drug called Elagolix or Alyssa has been out about 3 years now, and it is to treat the moderate to severe pain from endometriosis. It works by inhibiting GnRH, gonadotropin-releasing hormone. It inhibits that, which by inhibiting GnRH reduces pituitary secretion of FSH and LH, which decreases ovarian production of estradiol and progesterone. So you basically drop that estrogen and progesterone level to a very low level. You still have some, so that you don't get totally osteoporotic, et cetera, but it drops it almost immediately. Within a few hours, you have dropped that significantly. How does that differ from a GnRH agonist? Is that an agonist increases the estrogen, progesterone, and eventually it causes ovarian shutdown. But you do get that initial surge, et cetera. And so this Alyssa works faster than giving something like Lupron or some of those things. So the biggest concern here is if you drop that estrogen level, you get mineral or bone density decreases, osteoporosis, and then you can cause a hypoestrogenic type response, menopausal type response, night sweats, depression, anxiety, arthralgia, etc. So this drug has been around and is approved for endometriosis. Now, during the time this drug has been on the market, they have been looking at this drug for uterine fibroids, menageria, and other things. So let's talk about menageria for just a moment. 9 to 14% of women have it. Traditionally, we've treated this with NSAIDs like ibuprofen, naproxen, oral contraceptives, and then hormonal IUDs like Liletta, Mirena, etc. Newer therapies, Lysteta, which is tranexamic acid. This is the tranexamic acid is also available under the name cyclocapron for bleeding disorders. You see it used in surgery, etc. Stabilizes the protein, helps the blood to clot. So if you have bleeding disorders, you would use this same drug. So it helps with menageria as well. We also have the oral contraceptive Matasa, which is an estradiol valerate Dynagest combination. It's approved for contraception. It's also approved for menageria. And then the most recent approval is to take the drug Elagalex, the Oralisa, and combine it with a birth control pill, estradiol norethindrone, under the name Oralhan. Now, this was often done when patients were just taking the Oralisa. They would add in a birth control pill, but we recommended primarily a progestin only because the estradiol would increase the estrogen, and the Elagalex is decreasing the estrogen, and we just didn't know what would happen. But it has now been approved by the FDA for heavy menstrual bleeding associated with fibroids. So it's not a new drug. It's a fairly new drug called Elagalex, combined with estradiol and norethindrone, and approved for those two things. Would be the same side effects as you see from Oralisa and birth control pills: hot flashes, headache, etc., and then the bone loss. Now, most of the bone loss does return, but it's recommended not to take Oralisa or Oralhan for more than 2 years. And then have the standard warnings on all of the estradiol and norethindrone products. So what medical letter have to say about this? As you know from the past, I like medical letters' review of things. They're non-commercial. They say it's the first product to be approved in the U.S. for this indication. There is another gonadotropin receptor antagonist called Relgolex, which is approved for prostate cancer. It's being reviewed right now by the FDA in combination with estradiol and norethindrone for the same indication. But right now, it's not. The Oralhan is the only one approved. Let's mention a new term here, what we used to call atropic vaginitis, vulvovaginal atrophy. Even years ago, you saw senile vaginitis. That didn't sound very good. Which is the genitourinary syndrome of menopause, is a new term that describes these various signs and symptoms of that condition. It's estimated to be around 40 to 60% of women at menopause have some of these genitourinary symptoms. So that's now the new term, GSM, for the old atropic vaginitis or atrophy. Syndrome includes all the genital symptoms, sexual symptoms, urinary symptoms, affects the entire vaginal area with that. So we traditionally treat that with hormones, but not everybody, a lot of folks are scared of hormones. They keep on that non-hormonal drug to treat hot flashes. We've tried lots of things that I'll show you on the next slide, the SSRIs, gabapentin, et cetera. And I just wanted to tell you there is currently phase 3 trials of kisspeptin, neurokinin, beta-diaphorin neuron manipulation, KNDY. I've just told you everything I know about that, but these agents have been about 80% effective in the relief of hot flashes, improvements of other menopausal symptoms. So if you have a keen interest in this, Google that, KNDY, and see where they stand on the phase 3 trials. Just keep in mind that most clinical trials do not produce a marketable, approvable substance. Now, as I said, we've used lots of drugs, SSRIs, SNRIs, like Effexor or venlafaxine, the GABAergics like gabapentin, Lyrica. They've used clonidine, which is used primarily for blood pressure, oxybutynin, which is an anticholinergic for overactive bladder. All those, in some cases, have had some good effects, but they're not approved, FDA approved for that. I'll give you just a second to look at the title here, Vaginal Microbiome Transplantation. Now, if you are familiar with the fecal microbiome transplants for C. diff, this should not be that new, the concept, but they're talking about transplanting the vaginal microbiome in women who have bacterial vaginosis that's intractable. This is in a clinical trial, and that's at the bottom of the page. You can Google that if you want more information. But this is an interesting concept. It's not really pharmacology, but I thought it was interesting to look at. It's a very small trial, 5 patients. 4 of them was associated with full long-term remission until the end of follow-up at 5 to 21 months. So the authors of the study said therapeutic efficacy in women with intractable and recurrent BV should be further determined in randomized placebo-controlled clinical trials. So this is a very small study, very early in the trial, but it's something to keep in mind for your women who have this recurrent bacterial vaginosis. I mentioned gabapentin used for hot flashes and some of these things. Is it effective for chronic pelvic pain? This was a study in the British journal Lancet last September, and they said basically it doesn't work. And they said the study should cause us to rethink gabapentin's role in treating chronic pelvic pain. This is a double-blind study at 37 centers, randomized 300 women, 18 to 50 to gabapentin or placebo. They could go as high as 2,700 milligrams of gabapentin. That's higher than we normally use for neuropathy. 1,500, 2,000 is a pretty big dose. So they were using a big dose, and the results were similar in the gabapentin and the placebo groups. 7% of the gabapentin group with serious adverse events compared to 2% placebo group. So if it's similar outcomes with more adverse effects, they say it shouldn't be used as a first choice medication to treat this. By the way, also, I don't think I've got this in the notes or in the slides, but gabapentin was just made a controlled substance in most states. I think Alabama has it as Schedule 5. That's what it is in Tennessee. So it can be abused only in high doses when snorted, or there even rectal insertion of gabapentin. They're mixing up in fluid and stuff. It's crazy, but they're doing it. But it is a controlled substance now, so there may be extra precautions associated with that. And also the FDA has issued new warnings on respiratory depression. That's part of the reason it went to be controlled for both gabapentin and pregabalin or Lyrica. Fatal respiratory depression, particularly in patients with COPD, or the current use of opioids or other CNS depressants. Elderly patients are also at risk. So be very careful with this. Again, this is the real high doses that you see for really severe neuropathy or some of these others. These are FDA approved, as I said, for pain, insomnia, hot flashes, some of these things, but lower potential for abuse, but it does occur. You tell I like dogs. This is the reason a dog has so many friends, that he wags his tail instead of his tongue. What we might do right now is to take a short break, stretch our legs. I think I can have time to finish up on time, but let's take a quick break, and I'm sure that someone there, Beth or someone, Brandon, will tell you when we're ready to go back.
We will take a 15-minute break, and then we will return for the remainder of Dr. Farr's presentation. Thank you. Welcome back to our program, Striving for Excellence in Women's Health. Dr. Farr, please continue with the rest of your presentation.
Okay, I think we are back. If you see the slide, it says recent miscellaneous developments. That means we're going to talk about things other than women's health care right now. And this is always a challenge when talking to groups like yours. There's probably half of you that say, I just want to know about Depo-Provera. That's all I want to know. I don't want to know anything about anything else. And others, or half of you, say, I know everything there is to know about Depo-Provera. Just tell me about diabetes and blood pressure and some of these other things that we hear about. So I try in these kind of talks to do a little of both. I presented the information, the newest information, updated stuff on women's care. Let's move over to some other issues that might come up. We'll talk a little bit about diabetes. We'll talk about marijuana or cannabis and CBD and some other things that might be of interest to you. So let's get started. Looking first at something that you haven't heard anything about, I'm sure, COVID-19. In fact, as I said earlier, most everything the FDA is doing and most everything you read in the literature revolves around COVID-19. And I'm not going to go through all the stuff that you see every single day, but I do want to look at a few things from the drug standpoint of COVID treatment. The first thing we need to know is the only drug currently approved for COVID-specific treatment is remdesivir. This was approved in October of 2020. There's a lot of studies going on right now that have resulted in emergency use authorization of other things. There'll be more studies coming out, and many of these drugs may be approved by the FDA for COVID-19. But right now, remdesivir is the only one. So if you look at potential therapeutic classes, let's look first at antiviral therapy. Since COVID is a virus, then we would think that antiviral therapy would be first line. And it is with remdesivir. Remdesivir interferes with the action of viral RNA-dependent RNA polymerase, which evades the proofreading by these viral spikes on the virus, this XON, causing a decrease in the viral RNA production. So the virus cannot replicate and make RNA. And there's a slide on the bottom right of the slide has a little more information about it that you can Google if you really want to get into the mechanism. But it is an antiviral, similar to what we have to treat retroviral diseases like AIDS, etc. Then we have hydroxychloroquine. And you say, that's not an antiviral. Well, not officially. It's actually a quinine derivative. Hydroxychloroquine, chloroquine, quinine are all in the same family. They come from the bark of the cinchona tree, if you're interested in pharmacognosy. This became famous, of course, when President Trump talked about it. It's been promoted, it's been lauded as a cure-all. It's also been talked about as a ineffective drug, except for rheumatoid arthritis or some of the things that it's approved for. At this point in time, the FDA has said hydroxychloroquine has no effect on COVID-19. Now, again, you may feel otherwise, you may have read otherwise, but that's the FDA's position. Protease inhibitors, which are used primarily to treat HIV infection, may have a role either individually or in combination. And then antivirals like ribavirin, which is used to treat several viral infections. All of these have potential, but remdesivir is the one that is proved. The another class is immune-based therapy to affect the immune system. We know that corticosteroids do this, and the one that's received the most use is dexamethasone or Decadron, and that's been around for 60 years. Let me just caution, this dexamethasone or corticosteroids is indicated, and it's really not even approved, but it's recommended to use only in critically ill patients. You see the first word there under corticosteroids, critically ill patients that have an overwhelming inflammation and cytokine-related lung injury, which could end up in fibrosis. It should be adjunctive therapy. It could be useful to prevent or treat chronic lung complications derived from the disease. So if you've got, if there is such a thing as a normal, mild case of COVID, we do not recommend that you take dexamethasone for that at all. It actually may worsen by decreasing the immune response, which is a side effect of corticosteroids. So it has to be used very carefully. Now, there are other immune-based therapies, what they call interleukin-6, interleukin-1 inhibitors. There are several of these that have some use in rheumatoid arthritis, Crohn's disease, some of these things. Interferons have been around a long time, may play a role. The kinase inhibitors, again, if you look at these autoimmune diseases, Crohn's, rheumatoid arthritis, some of those, the drugs used for that may potentially have a role for COVID-19. There's a lot of miscellaneous things that we've seen used. There's a lot of talk about vitamins, particularly vitamin D and zinc, even recently some things on vitamin C. There's been a couple of small studies on famotidine or Pepsin. Now, we have not seen the same data. It's an H2 receptor antagonist used to treat hyperacidity conditions. We have a similar drug, Tagamet or cimetidine, or Zantac, ranitidine, that we have not seen those two drugs be promoted. Ranitidine actually took a hit in that it had something in the tablet, et cetera, that could cause cancer. So I don't think it was a major thing, but that got a lot of negative publicity. Hyvermectin, this is a veterinary product that is used in humans. It's used as an anti-parasitic, actually used for head lice, we'll talk more about in a moment. It has been shown to maybe have some effect. Antibacterials, and you say, how can antibacterial kill a virus? Well, we don't know, but it may have. There's been some talk of ACE inhibitors, like lisinopril and some of those, and ARBs, angiotensin receptor blockers, that may have a role, and then antithrombotics, particularly due to some of the clotting that we see with COVID-19. So I would see that as an adjunctive treatment. If needed, you might put somebody on heparin or Coumadin or one of the low molecular weight heparins. So those are miscellaneous things. There's a lot in the literature, good and bad, about some of these, but none of those are approved. There's also antibody therapy. You hear a lot about convalescent plasma, where you take the blood or the plasma from a person recovering from that, and similar in theory to vaccinations. That has been done with success in some. IVIG, immunoglobulin, has been used. Probably the most is from the polyclonal and monoclonal antibodies. Regeneron, you heard a lot about that. Eli Lilly has a couple that I'll mention in just a moment. These bind to the viral surface and they block the entry to prevent infection. So right now, remdesivir, convalescent plasma, and these polyclonal, monoclonal antibodies seem to be what we are trending toward in treating these patients. I mentioned Lily had two that just received emergency use authorization. These are monoclonal antibodies, bamlanivimab and atezolizumab are used together, not separately, but in combination. They're authorized for use under an EUA for the treatment of mild to moderate COVID-19 with positive results of direct SARS-CoV-2 viral testing, who are at high risk for progressing to severe COVID-19 or hospitalization. So again, not everybody would qualify under the FDA approval or the EUA approval for these. But my point here is that there's something new almost every day coming out with these. And this was just a few weeks ago that the EUA for these two was given. So keep your eye on this. I think there'll be some significant changes coming in the future. Now, I ran across this. What did President Trump receive as treatment? They threw the whole shebang toward him. He got Regeneron's polyclonal antibody. He got remdesivir. He got dexamethasone, zinc, vitamin D, famotidine, and then I hadn't heard about melatonin, but he got it, and then daily aspirin for the antithrombotic effect. So basically, President Trump was treated with everything that has been talked about, except the hydroxychloroquine, interestingly. He was promoting that, but he did not receive that at the hospitalization. This was when he was hospitalized. He may have received it prior to that, we don't know. But I just thought it was interesting to see what was used to treat the president. Rather than going through in depth about all this stuff that you're not going to remember, and I just saw a typo, COVID-19, I'll remember to correct that. But you can go to the NIH guidelines, you can go to the Infectious Disease Society of America guidelines, or the World Health Organization guidelines. If you just type into the search engine NIH or IDSA or WHO COVID treatment guidelines, it will tell you what is recommended right today for COVID-19. And I'll tell you they vary just a little bit. There are a lot of similarities, but there is some variation in what is recommended for treatment. So that, if you're interested, that can give you some good additional information for COVID. There is one thing in the IDSA treatment guidelines that I wanted to close with here, what I opened with. There is no game changer for the treatment of COVID-19. They're continuing to examine the available potential treatments. Remdesivir is the only one that was full FDA approval. So keep your eye, there'll be things coming in the future. All right, switching gears quite a bit here. What are the benefits of dark chocolate? We've talked about this for the last 30 years. There's supposed to be some phenols and something that in dark chocolate that have a cardioprotectant effect, lower blood pressure and all that. Excuse me. Here is the latest study. This was not eating dark chocolate, this was drinking cocoa. So hot chocolate. So particularly in the wintertime, this might be something to consider. Small study, 44 patients, 60 and over, to prevent peripheral arterial disease. They drank cocoa 3 times a day. Significantly greater improvement in 6-minute walk distance compared to the placebo group. Also, they showed improvement in perfusion of the legs, improvement in calf skeletal muscle characteristics, improved function of the mitochondria, etc. So drink cocoa and it might prevent PAD in you. Now, if you drink it 3 times a day and there's 150, 200 calories and a lot of those cocoa, you may get obese and that may worsen your PAD. But anyway, right now, that's the latest study on chocolate. I saw this interesting. I thought this might be interesting. The state of Hawaii was ordered to pay, the manufacturer was ordered to pay the state of Hawaii $834 million over Plavix warning label. And one of the reasons I mention this is I think this is the first time I've seen this done, but it also gives me a chance to talk again about genetics and the role that pharmacogenetics is playing and will play in the future from drugs. If you know or didn't know, clopidogrel or Plavix is not active until it is metabolized in the liver to an active compound. So you've got to have the appropriate liver function and genes to do that. About 14% of Chinese patients do not properly metabolize it. About 4% of Black patients and 2% of white patients do not have that. So if we do genetic studies and we know on the front end that this person does not have these genes to metabolize clopidogrel, then we wouldn't give them clopidogrel. We wouldn't waste their money and subject them to side effects, etc. So I think you're going to see more things like this where they're basically saying you've got to warn patients or even do genetic testing for certain drugs, not all drugs, but certain drugs. Codeine is another example. It's converted to morphine, and if you have a fast metabolizer, you can get morphine toxicity, particularly in little kids. So anyway, keep that in mind that genetics play a major role. New type of cholesterol drug. The statins have been around for years. They are now all generically available. And so they work, and they work well, but there's a certain percentage of the population that just cannot tolerate the muscle aches and pains, joint pain that these drugs cause. Also, there's some people that even when you maximize the dose, they do not bring you to the goal treatment for LDL cholesterol. So we're always looking for something new for cholesterol. Well, we've got a new drug just approved a few months ago called bempedoic acid. Brand name is Nexletol. It's also approved in combination with ezetimibe or Zetia, that under the name Nexlizet. So you've got Nexlizet has two drugs in it, ezetimibe and the bempedoic acid. It is approved for adjunctive therapy, maximally tolerated statin therapy for adults with this heterogeneous familial hypercholesterolemia, which is really high cholesterol. It works on adenosine triphosphate citrate lysase, ACL. That's not your ligament in your knee, but it is an enzyme which blocks the production of LDL cholesterol. So you decrease production of LDL. Statins do the same thing, but they work on HMG coenzyme A reductase. So this is a different enzyme. The reason this might be different and better is that when you inhibit HMG coenzyme A reductase, that also inhibits the manufacturing of coenzyme Q10 or ubiquinol, which has a role to decrease has effect on muscle function. And we think that the lack of coenzyme Q10 may be what is causing the muscular problem, muscle soreness, because we can supplement about 300 to 400 milligrams of CoQ10 a day with statins. Sometimes takes care of some of the pain. Not always, but sometimes. How did it do in clinical trials? Reduced LDL average of 18% compared with placebo in patients already taking moderate to high dose statins. 28% reduction in taking low dose or no statins. Now, that's not quite as good or beneficial as statins, but if you can get an additional 18% if you're already on a statin, that may be very, very important. Adverse effects for this: uric acid elevation can cause gout-like symptoms and ruptured tendons. Now here's an off-the-wall question. what class of antibiotics is associated with tendon rupture? I'll let you think about that for a moment. If I were live, I'd call on somebody, but the answer is the fluoroquinolones, like Cipro, some of those. Okay, let's shift over to diabetes. And we have seen a major paradigm shift in the treatment for diabetes. We have two groups of drugs, fairly new. They've been out 5, 6 years, 7 years maybe. The GLP-1 receptor agonist and the SGLT2 inhibitors. These drugs are shifting the paradigm in the way we treat type 2 diabetes, not so much from just lowering blood sugar, but patients with atherosclerotic vascular disease, heart failure, and kidney disease. This is a statement, consensus statement from the ADA, as well as the European Association for the Study of Diabetes. Okay, sodium glucose cotransporter 2 inhibitors. These all end generically in the name Flozin. So canagliflozin, dapagliflozin, empagliflozin, etc. So these are the Flozins. What they do is to make you pee out glucose. So it prevents the resorption of glucose in the kidney, so you excrete it in the urine. And you say, wait a minute, you're not supposed to have glucose in the urine, that's an indication of diabetes. Well, if you're taking an SGLT2 inhibitor, you should have glucose in the urine. And the other benefit is if you're peeing out glucose, you're not getting those calories from the glucose, and you may lose weight. So there are 4 of those drugs on the market: Invokana, Farxiga, Jardiance, and Steglatro, and that's the way they work. The glucagon-like polypeptide 1 agonists, or the GLP-1, these work to stimulate the release of insulin. You say, well, that's the way the old sulfonylureas like glimepiride and those do. Yeah, but it also affects glucagon secretion, it's reduced, and gastric emptying is delayed. So we're not getting that rush of glucose from the stomach and the gastrointestinal tract. These all end in ATIDE, exenatide, liraglutide, etc. These have been around a little longer. Byetta was the original injection that was derived from the saliva of the Gila monster. If you remember talking about that or hearing about that, they called it lizard spit. And then all the way down to semaglutide. Ozempic has been around for a couple of years. They just released last fall Rybelsus, which is an oral. All the others are injections. So is there an advantage to not having to inject something? Yeah, a lot of people would rather swallow a pill than give an injection. Now, going back to the SGLT2, a breakout year, shifting paradigms. You're hearing all this. I mentioned that they not only lower glucose, but look here, cutting heart failure, slowing progression of chronic kidney disease, regardless of the diabetes status. Now you were thinking, well, yeah, if you lower your blood sugar, you're going to prevent complications from kidney disease and heart failure. These are in patients regardless. So what we see now is the manufacturers of the SGLT2 inhibitors used to market only to endocrinologists and people for treating diabetics. Now they are marketing to cardiovascular, cardiac folks, cardiologists, as well as nephrologists. So this has become a top-tier agent for millions of patients with not only diabetes, but also cardiac or renal disease. So these are kind of like we saw with ACE inhibitors and ARBs many years ago in protecting kidney and blood pressure, et cetera. So there's a lot of excitement out there about those drugs. I mentioned the SGLT2 inhibitor semaglutide or Ozempic, that all of these could cause weight loss. This is the one that is most associated with weight loss. It's one that's been given studies, or done studies with. But once weekly injections of semaglutide or Ozempic reduced body weight significantly in patients, again, with and without type 2 diabetes, and given in addition to lifestyle interventions. So it's been approved for several years, but it's been primarily seen in diabetes. Now we see it in non-diabetics. Speaking of weight loss, they took a drug called Belviq or lorcaserin off the market last February. There was an increased occurrence of cancer in patients taken for weight loss. I don't think that it was used that much. All these weight loss drugs, several of them came on the market and created a lot of stir, but they really haven't turned out to be that effective long term. So Belviq is gone. There is a new insulin glargine out called Semglee. It is an insulin glargine product similar to Lantus. Now, listen closely to what I'm saying here. It's the second follow-on insulin glargine to become available. Basaglar was the first. Now, when I said follow-on, you probably hadn't heard that term or didn't know what I was talking about. People will refer to this as generic Lantus. In fact, my neighbor came over the other day and he said, I've had diabetes. Metformin hadn't controlled it. I tried that SGLT2. I don't remember which one he was on, but I couldn't take the side effects. The GI side effects are pretty bad in some folks. So anyway, he's going to put me on insulin. And he said, there's a new generic Lantus out. And I said, well, there is a drug similar to Lantus, but it's called a follow-on. It's not generic. And it's not that much cheaper. That's the problem. That's what we generally talk about with this. So they're all similar in composition, strength, biological properties, and similar clinical results. But the manufacturers and the negative folks would say in a way to keep the price up, they're not considered interchangeable or generic equivalent. So you can't substitute one for the other without permission from the prescriber. And again, they're not that much cheaper. Which brings up the whole concept of insulin prices is a big, big topic in the lay news. It's upwards of $300 plus a month now for just basic insulin, where it used to be $20 a month. And one of the reasons is there is no generic insulin around. There are the follow-on, there are the biosimilars, but not generic. So this compares this, if you're interested in the cost. Lantus, they did lower the price a little bit with the pen injectors, and the Semglee is a little less, but even since this was put out, the prices have been adjusted, and they're fairly similar, depending on the managed care organization that you're with. They may have one or the other that they get a deal on. So anyway, that's the Semglee. This is not sugar and spice, but it is a picture that I saw that looks just like sugar and spice. But you gotta love dogs, and they hug each other. Supposedly they had been apart for a while. Sugar and spice are that way. They are always together. They've never been apart their entire life. And I don't look forward to the day that one of them goes to doggy heaven without the other. All right, let's continue on with some more miscellaneous things. Anticholinergics, 50% greater dementia risk. If you read literature or geriatric literature, they're really, really concerned about the use of anticholinergics in older people. They lead constipation, urinary retention, dry mouth, blurred vision, all those things that occur a lot in the elderly anyway can be exacerbated with these anticholinergics. But now they're saying studies are showing an increase in dementia risk. And you can see the listing there, antidepressants 1.29, that would mean 29% increase. Anti-Parkinson's, that doesn't mean 29% of people taking them get dementia. Make sure you understand statistics. Anti-Parkinson's, antipsychotics, bladder antimuscarinic or anticholinergic drugs. Some of the anti-epileptic drugs have anticholinergic side effects. The one that they did not list, and I read the article and they did not test this, was antihistamines such as Benadryl. They have significant anticholinergic effects, and a lot of older folks and younger take Sominex DPH or Tylenol PM. If you're wondering what is the ingredient that makes you sleepy, it's diphenhydramine or Benadryl in those products. So I'd be careful recommending those as well. Benzodiazepines, Xanax, clonazepam, lorazepam, Ativan, Cilax, Valium, there's a lot of them. Last September, the FDA said we're updating the box warnings on benzos to reflect their serious risk of abuse, misuse, and withdrawal. There's already a box warnings, but now it's even more serious. So this is kind of like I told you once, I'm telling you again, be careful of abuse and misuse and the dependency that benzos can cause. 2019, the FDA estimated 92 million benzo prescriptions dispensed in outpatient pharmacies, prazolam, clonazepam, lorazepam. In Tennessee, in the controlled substance database, benzodiazepines are 3 of the top 10 drugs, Xanax being the 3rd most prescribed controlled substance in Tennessee. And I would assume it would be very similar in Alabama. So be very careful. Also, be careful about mixing benzos and opiates. That's another black box warning that we talked about a couple of years ago. A couple of things that have been switched from prescription to OTC. Birth control pills may appear on this someday, but right now, probably the biggest one was Diclofenac Topical Gel. It's a 1% Voltaren, or arthritis pain is the name of it. Diclofenac is taken topically. I mean, it's taken orally, but it's also affected topically. For many years, pharmacists were compounding Diclofenac and other NSAIDs. It was approved in 2007 as a prescription drug, but it's also now approved for over-the-counter. Same strength, 1% strength. And then a couple of eye drops, 2 dosage strengths of olopatadine or Pataday. This used to be called Patanol as a prescription drug for allergic conjunctivitis. So you can get that now over the counter. So what you used to have a prescription for your achy joints, knee, etc., or your itchy eyes can now be purchased over the counter. More and more drugs come over the counter every day, and so we need to make sure patients understand just because it's over the counter doesn't mean it doesn't do anything. They're still very potent, very active drugs. We got another one, Hyvermectin. Splice was a prescription product, been out probably 10 or 12 years. It is now available over the counter. Single-use treatment for head lice, 6 months and older. You don't want to use it with little kids. A lot of head lice occurs. This is, when it was prescription, was used primarily second-line agent to the pyrethrins. But just as we've seen bacteria and other things develop resistance, we saw the little head lice also develop a lot of resistance that you would need to go to ivermectin. It's still much more expensive than the pyrethrins, but it's now over the counter and hopefully a little bit less expensive than it was as a prescription drug. And then we have now an ibuprofen acetaminophen combination called Advil Dual Action. And one of the reasons that we're seeing this combination is the last few years has seen a lot of support for the combination of ibuprofen and acetaminophen instead of opiates, particularly for dental pain or real minor surgery, etc. This contains 250 milligrams of ibuprofen and 500 milligrams of acetaminophen. So you can make your own, but you can't really make this exact thing because ibuprofen is available 200, 300, 400, 600, and 800, but 250 is not, and that's why they do this. They want to sell you Advil dual action rather than generic Advil with generic acetaminophen, which would be cheaper. But the acetaminophen dose is the same as extra strength Tylenol, 500 milligrams. Keep in mind, this is basic knowledge, the maximum daily dose of acetaminophen is 4,000 milligrams. That's 8 extra strength Tylenol tablets. And a lot of folks take that amount or more and then take other products. Oh, I take Advil dual action and extra strength Tylenol for my pain. And they're wondering why their liver enzymes are up. And oh yeah, I have 3 glasses of wine every night with dinner. They're going to eat their liver up. So anyway, the dental associations are very much in favor of this, particularly now that controlled substances have to be prescribed electronically and a lot of restrictions. Let me finish up with cannabis. This is one of those things that we could probably talk 2 hours about. Marijuana, cannabis, CBD, all these things, that's for the last 2 or 3 years has been very much in the limelight. So let's review a few things about this. In 1937, you could you could prescribe cannabis. It was a prescription drug. And one of the reasons that it was a prescription drug is it could be taxed. They passed the Marijuana Tax Act, which placed prohibitive tariffs and registration requirements on cannabis, and that kind of reduced the use of it as a legitimate drug, and it kind of went to the streets. Also in the 30s, CBD was isolated from the cannabis sativa plant. You thought CBD was something in the 2000s. It's been available. In 1942, 5 years after it was a prescription drug in the Tax Act, they removed it from the United States Pharmacopoeia. And then in 1970, the Controlled Substance Act came out, and marijuana was assigned Schedule I status. So, quick review of the Controlled Substance Act. Schedule I are drugs like LSD, heroin, ecstasy, and marijuana that have no legitimate medical use in the United States. Schedule I. And then as we go through some of the slides, I'm giving you a little more information for the slide. There is a prescription tetrahydrocannabinol drug called Epidiolex on the market. And you say, how could it be? Schedule I means no legitimate medical use. Therein lies the problem that we have with dealing and studying cannabis. It is not legal to possess it. You say, well, how California, Colorado, Utah, it's legal. New York just passed legalized recreational marijuana just last week. So how do they do that? That's a great question. The answer is, it's a Schedule I, but it's not enforced. And like so many laws that we have on the books that are not enforced, this is one of them. So until marijuana is descheduled by the FDA, I don't think we're going to have a lot of scientific study of the drug. So with that in mind, let's look a little bit more. Cannabis contains more than 60 pharmacologically active cannabinoids. The main one, the reason that people smoke marijuana, is to get delta-9 tetrahydrocannabinol, or THC. Another reason that another metabolite or cannabinoid is cannabidiol, or CBD. That's the best known, and that's the one that's sold over the counter. So THC is psychoactive. CBD does not produce euphoria or intoxication. As of November last year, 35 states permit some medical use of marijuana that contains THC. Even though it's a Schedule I drug, the states, 35 states have approved it. And now I think we have 6 or 7 or 8 states that have approved recreational use of marijuana. But in those states that approved it, it's available with varying restrictions and requirements. Some require certification for each individual patient signed by a physician or another healthcare provider. Some don't require anything. So they vary considerably. So then the question, what's the difference between CBD and cannabis? Well, cannabis is the scientific name of the plant, Cannabis sativa, while CBD or cannabidiol is a chemical contained in the cannabis plant along with about 60 others. But what's the difference between CBD and hemp? We'll talk about the Farm Act, which legalized hemp. Well, hemp is a variety of cannabis grown specifically for fiber that's for industrial purposes, ropes and clothes, etc. You can buy hemp clothes. Hemp does not have very much THC. Actually, it has to contain less than 0.3% THC to be, quote, legal. And so that basically has very low levels of THC. So you've got hemp, CBD, and THC. Back to the legal things. Marijuana, Schedule I, but in 2018, Congress passed the Agricultural Improvement Act of 2018, so-called Farm Act, that stipulated that cannabis containing no more than 0.3% THC can be defined as hemp and is not a controlled substance under federal law, but individual states have their own regulations. So if it's hemp, it's not a Schedule I. If it's marijuana or contains THC, it is Schedule I. So if you're a lawyer, you can try to dissect that and tell me what the legal status is. I would be interested in knowing that. To further complicate the matter, we have phenatobanol under the name Marinol capsules and Syndros oral solution that's approved for nausea and vomiting related to chemotherapy. It is a cannabis product. We have Nabilone or Cesimet, which is approved for nausea and vomiting for chemotherapy, which is a cannabis product. These are FDA approved drugs that either Schedule II for Cesimet, Schedule III for Marinol. That doesn't make any difference. There's no rationale for the difference there. And then we have, to really complicate things, Epidiolex, which is CBD, which is approved for 2 very rare types of epilepsy, but as a prescription drug. And if you look at the label there, it's a Schedule I controlled substance, which has no legitimate medical use, but it is approved by the FDA. So if you're confused, join the crowd with me and millions of others about the legal aspects of this. Now, one of the problems in buying CBD at your local green store is that you really don't know what you're getting. This was a 2017 JAMA study that purchased CBD products online. They looked at liquid chromatography, very, very precise, to access the accuracy of the labeled CBD content. They looked at 84 products 58 of those contained CBD concentrations that were 10% or greater above or below the labeled content. 18 of those had potentially intoxicating concentrations of THC. And then there's also been contamination of cannabis with pesticides, heavy metals, etc., to give you something else to worry about besides whether or not it contains THC. So are your patients taking CBD? 1 in 7 do. 11% are 50 to 64 years of age. It's not just kids. 8% are at least 65 years of age. What are they taking it for? Pain relief, anxiety, insomnia, arthritis. 4 in 10 Americans think CBD oil should be legally available for adults to buy over the counter. Well, they are, in most places, available over the counter. Now, going back to the previous slide, that there was a big discrepancy. Many of the 18 of those products contained intoxicating levels of THC. Now, one of the problems in the legal aspect of THC is the only drug we have a specific level indicating in per se impairment is alcohol. We don't have that with opiates, benzodiazepines, or marijuana. And the reason we don't is the significant issue of tolerance. Opiates and benzodiazepines specifically. I mean, man, I've seen patients take 30 and 40 Oxycontin capsules, crush them up and snort them. It would kill me before I even got the first snort in. But they can function just fine. So, with cannabis, we do not have a recognized national standard. However, states that have approved cannabis, primarily in the West, now New York, have put a limit of 5 nanograms per mil of THC. Some states actually have a zero tolerance. If you have THC at any level, you're considered impaired. But I think one state, I believe it's Utah, has a level of 3 nanograms per mil. Well, what does that mean? Well, it doesn't mean a lot, except you probably smoked or used marijuana pretty close to the time of the accident. But if you look at the last bullet, you're involved in a accident or a traffic stop. The officer looks around, has you do some tests, talks a little bit, looks around, and then makes the decision that you're impaired and arrests you, takes you to the hospital to draw blood, and an hour and a half has passed. If you look at THC, as soon as you smoke it, it just really spurts right up in concentration, above 100 nanograms per mil in many cases. And then by 3 hours, it's less than 5. It's almost non-detectable. So you use marijuana an hour before the wreck. It was an hour and a half, and so you had the wreck, and hours passed, an hour and a half before you get the blood drawn, and the level is 3 or it's not detected. Now there's a metabolite called carboxy-THC that will last for days and weeks, but it's not pharmacologically active. So the problem is that the level was probably 40 or 50 at the time of the accident, but now it's showing up as 0 or 2 or whatever because it takes so long to get it. It's same issue with cocaine. Cocaine leaves even quicker, and so you just test for the metabolite of cocaine. So in a zero tolerance case, you use cannabis 2 days ago, there's still some carboxy-THC in your system, and we can detect it. And if you sign a contract with the company you're working for, if you ever test positive for marijuana, you're fired. They can fire you. But if you had a wreck and you said, I smoked weed 2 days ago, there's not any THC detectable at that time. So if you're taking CBD, can you test positive for marijuana on a urine drug screen? And the answer is yes, because 18 of those products had high levels of THC in them. I had a real sad situation. I do some expert witness work. I had an attorney call me just a few months ago representing a police officer who said he was using CBD oil, I think to help him sleep or something. And he was involved in an accident where he had to draw his gun. And when you do that, they test you to make sure that you weren't impaired or whatever. And he tested positive for THC. And this was an officer that had been with the force for years, and he was fired because, he tested positive for THC, or marijuana metabolite at that time. And it's a zero tolerance thing. He swore he did not use marijuana, but it cost him his job. So my advice on CBD is either don't use it, or don't use it particularly if you are subject to random drug screens, and it's a zero tolerance case. Now, the other side of the coin is your CBD oil may not contain any THC, and it may not even contain CBD. Since it's not regulated, there's no way to assure that you're getting what it said on the label. So it's a very interesting thing to look at. To further examine this issue of what's on the label versus what's in it, just a few weeks ago, the FDA warned 2 manufacturers about illegal marketing of drugs containing CBD for OTC use without an approved new drug application, for using substandard manufacturing process and failure to comply with good manufacturing practices. So they are really cracking down on these things about what's in it, how is it made, et cetera. There's been 51 previous warning letters issued by the FDA since 2015 to these products. And they state CBD has known pharmacological effect on humans, a demonstrated risk. It cannot be legally marketed as an inactive ingredient in OTC drug products that are not reviewed and approved by the FDA. So why can't the FDA go in and take them off the market? Well, perhaps they could, but there's other places that say this is sold as a supplement, just like you sell vitamins and other things. So it's a very, very cloudy issue regarding the legality, what's in it, et cetera. And we haven't even gotten into the discussion of whether the CBD oil has therapeutic effects, et cetera. That's being looked at and will be studied more, but right now that's where we are. Now, you may have seen this slide when I was there before, but as I mentioned at the start, I have semi-retired to professor emeritus status. And somebody asked me about retirement, and I said, well, you kind of know when it's time to retire. I didn't do like this lady with whiteout, but I think you kind of know when it's time to move in a different direction. And that's what I've done. I want to stay active and doing some of these things, but I also want to spend some more time with the grandkids and the dog, et cetera. But I'm really happy I got the opportunity to spend some time with you today. And with that, I feel like the Family Circus guy says, that's it. I'm done learning for today. So I'm going to turn it back over to Brandon, and I think we'll have the ability to do some questions and things when this is presented on the 16th. Brandon?
So thank you, Dr. Farr, for that wonderful presentation. He always makes us think, and that's how we know that it's a fulfilled time for pharmacy continuing education. We're going to go right into our next speaker, and it's one of our own. I mentioned yesterday that we have a special guest today, and her name is Ginger Phillips, and Ginger is one of our nurse practitioners and has been with us for many years in the nurse practitioner role and has pursued her doctorate in nursing practice, and we're very very happy to have Ginger present her project to us today.
Hello everyone, I'm Ginger Phillips. I'm a nurse practitioner in the West Central District, and I'm also a DNP student with the University of Alabama. I will be graduating on May the 1st, and I was asked to share the findings of my Quality Improvement DNP Scholarly Project with you guys today. And so we're going to go ahead and get started with that. The title of my project is Improving Adherence to Public Health Follow-Up Care Standards for Underserved Women with Abnormal Cervical Cytology. Since the ADPH colposcopy program's inception, the goal of the program has been to reduce cervical cancer mortality rates with early detection through a community-based program, thereby improving patient services. The ADPH colposcopy program seeks to assist the women with barriers to follow-up care, such as financial and transportation issues, as do patient navigation programs. By providing colposcopy within the county health departments, continuity of care is maintained, eliminating the need for outside referrals. This quality improvement project involves an expansion of the ADPH colposcopy program, if you will, including the use of patient navigation efforts to get our clients who are in need of colposcopy by identifying and acting upon barriers that may impede their ability to get to their appointment. These are the objectives that I hope that you will reach after we finish this presentation. We're going to discuss the impact of cervical cancer in low-income minority women within the United States and the state of Alabama. We're going to discuss how patient navigation programs can assist vulnerable population groups to recommended follow-up. And we're going to discuss prepare guided navigation and how that is used to determine social determinants of health that could impede the follow-up process in this vulnerable population group of patients that we all serve daily. And then we're going to discuss the results of the QI project that was completed to improve adherence to ADPH follow-up care recommendations. For our clients, we're going to discuss ways in which patient navigation efforts can be utilized more effectively within our agency and potentially become a standard of care for the women who are in need of diagnostic resolution of their abnormal Pap test. Just a few background and statistics I have listed here. The prevalence of cervical cancer has decreased over the past 25 years, but the disease continues to be a significant healthcare concern that disproportionately affects minority women. The overall decline in the incidence of cervical cancer can be contributed to more effective screening practices and new guidelines, and an increased number of women who actually receive age-based screenings, and the number and the development of the HPV vaccine. Precancerous lesions can be detected, can be treated before they develop into invasive cancer, making cervical cancer highly preventable. Despite these medical improvements, the failure of women to adhere to recommended follow-up after abnormal cytology is detected can lead to invasive cervical cancer. The National Cancer Institute estimated in 2017 that 291,704 women were living with cervical cancer in the U.S. And the American Cancer Society estimates that this year 14,480 new cases of invasive cervical cancer will be diagnosed and 4,290 will die from cervical cancer. And in Alabama in 2017, 238 new cases of cervical cancer were diagnosed and 89 women died from cervical cancer in our state. African American women do have the highest mortality rate of cervical cancer in the United States, while Hispanic women have the highest incidence. The mortality rate with African American women has actually been compared to those women who live in third world countries, particularly those women who reside in the Black Belt region of our state, where the population consists there of a lot of uninsured low-income minorities, and there are also a limited number of health care providers in that area. So limited access to care, cost, and other social determinants of health may explain the disproportionate impact of cervical cancer in African American women in the United States and in Alabama. This is a map. I'm sure all of you know this already, but it depicts the Black Belt region of the state, which includes 17 counties extending across mid-central Alabama. 4 county health departments in the Black Belt serve as locations for ADPH colposcopy services, and those are Bibb, Butler, Dallas, and Montgomery counties. The problem statement for my QI project was underserved females who receive cervical cancer screenings from rural county health departments often fail to adhere to Pap smear follow-up recommendations after an abnormality is found. Failure to adhere to those recommendations can increase cervical cancer incidence and mortality rates in this vulnerable population group. One strategy to potentially improve adherence rates to follow-up care standards is the addition of a patient navigation program into the current abnormal Pap smear follow-up process. This evidence-based intervention would allow the patient navigator to identify and respond to social determinants of health guided by the PREPARE standardized social risk assessment tool. This would increase follow-up adherence rates, hopefully decrease the incidence and mortality rates of cervical cancer, as well as the costs related to the treatment of cervical cancer. By conducting this evidence-based quality improvement project that includes the addition of the patient navigator into the current abnormal PAP follow-up process, this strategy could also potentially support policy requirements of the National Breast and Cervical Cancer Early Detection Program, raise awareness of the Community Health Advisor Program, which is a Title X supplemental grant, and meet the objectives of the ADPH strategic plan for the years 2019 to 2023, such as improving health outcomes. So what is PREPARE? PREPARE is an acronym for Protocol for Responding to and Assessing Patients' Assets, Risk, and Experiences. It is a national standardized social risk assessment tool that was developed in 2016 by the National Association of Community Health Centers, and it was designed to align with social determinants of health initiatives such as Healthy People 2020. This 21-item survey consists of a set of 4 core measures as well as a process for addressing the social determinants of health at the patient and population level. The core measures include personal characteristics, family and home, money and resources, and social and emotional health. There are 4 additional questions that include questions about incarceration status, refugee status, safety, and domestic violence. This tool is used to assist providers to achieve population health goals while improving health outcomes and reducing costs to treatment. Here is a link to the survey retrieved from the National Association for Community Health Centers. And here's a copy of the 21-item PREPARE survey. Because this is free to the public, there was no need to request permission to utilize this instrument for my QI project. The PICO, or clinical research or question, or the formula for developing answerable researchable questions for this QI project, is in women in an underserved public health setting with abnormal cervical cytology, does patient navigation guided by the Prepare standardized social risk assessment tool improve adherence with recommended follow-up over 3 months compared to follow-up without navigation? So first, the show rates for 4 public health colposcopy clinics before and after the implementation of Prepare-driven navigation were measured and compared. And those 4 public health clinics included Bibb County, Cullman County, Dallas, and Shelby. So the show rates included those appointments kept in the 4 clinics at 3 intervals. Those were the appointments kept under usual care, follow-up care under prior to the COVID-19 pandemic. Those were labeled pre-COVID. Appointments kept during the height of the COVID-19 pandemic, labeled COVID, and then those appointments kept after the implementation of Prepare-driven patient navigation, labeled post-implementation. So Prepare-guided patient navigation was conducted via phone calls and mail by the primary investigator, which was myself. Prepare-guided navigation was administered to underserved women who were scheduled to receive abnormal PAPS follow-up care at the 4 county colposcopy clinic sites over a 3-month period, which occurred in August, September, and October of 2020 in Bibb, Cullman, Dallas, and Shelby County Health Departments. The use of the Prepare survey allowed the primary investigator to not only recognize but respond to reported social determinants of health that may have prevented them from adhering to follow-up care standards. So the Prepare, if the participant could not be reached by phone, the Prepare survey was mailed to them along with a waiver of written consent with a self-addressed stamped envelope for the participant to return. So let's talk about the results. So like I said, the pre-COVID and COVID colposcopy clinic show rates under usual follow-up care were measured and compared to the show rates of the clinics after the implementation of Prepare-driven patient navigation for each county health department and as an overall total for all 4 clinics. The overall analysis did reveal statistical significance for pre-COVID rates versus post-implementation rates, as well as COVID show rates versus post-implementation show rates. The results for the individual counties were not statistically significant, with the exception of Bibb County. The individual clinic numbers were not powered enough. They were small. They weren't powered enough to be statistically significant. However, the individual county rates were clinically significant in that there was notable improvement in the percentage of the post-implementation show rates for each of the 4 county health departments after the intervention. So you can see on this table, if you look at the bottom of this table, it shows the overall show rates for each county. So these were all statistically, this was what was statistically significant. We compared pre-COVID to post-implementation, and then COVID to post-implementation. So you can see that these were statistically significant. Chi-square analysis was used to analyze this data. And so even though the results were not statistically significant for the individual counties, you can see how from pre-COVID to post-implementation, what a huge percentage increase there was for each one of the counties individually. Bibb was 62% show rate pre-COVID under usual follow-up care, 88% after the implementation, 73% for Coleman to 90%, and then 65% for Dallas to 83%. So slide shows the overall county show rates at each interval, and this is pre-COVID, COVID, and post-implementation, and this is overall, all the numbers totaled together. This is another comparison of show rates by county and overall. You can definitely see how the numbers increased. These are some of the sample characteristics, the core and additional measures of the 37 total participants were navigated to their colposcopy appointment using the 21-item Prepare Social Risk Assessment tool. And I'm not going to read through all of these because of time. I would like to say that 2 immediate referrals I made during the phone calls for a report of depression and domestic violence to community outreach services. The women were also seen in the clinic on the day of their colposcopy appointment by the ADPH Title 10. So that should be social worker, not community health advisor. Anyway, they saw them on the day of their appointment. So it just, says to me that if we had not screened them for this, we might not have ever known, and the women might not have ever gotten the help that they needed. So the findings of this project definitely support the need for patient navigation efforts within public health clinics. The National Breast and Cervical Cancer Early Detection Program supports the use of population-based approaches to improve the value of breast and cervical cancer screening and diagnostic services. And so one approach includes implementing evidence-based intervention strategies such as patient navigation efforts exemplified in this QI project. National Breast and Cervical Cancer Early Detection grantees such as the ADPH are in a perfect position to present the findings from this QI project as an evidence-based patient intervention strategy in order to receive additional funding for navigation services from the CDC and its partners. In order to provide patient navigation services within the ADPH that would identify and address barriers while facilitating access to recommended follow-up standards, a social work position would need to be written into the already existing ABCCEDP protocol. That protocol would then need to be revised to include navigator responsibilities. The salary for the social worker would need to be budgeted into the funds already allocated for this program, which includes screening and diagnostic services. The ADPH currently employs social workers who work in grant-funded programs who could be trained as patient navigators in each public health district. Therefore, no new staff would need to be hired for this position, as one of the current social work staff members could be reassigned to this program in each public health district. The patient navigation program could, however, be piloted in 1 or 2 public health districts prior to initiating this program statewide. The ability to provide funding for a patient navigator will be dependent upon available funds allocated for the grant year. A second approach to providing patient navigation services to the vulnerable population group is increased utilization of the Title X Care Coordination Program. The social workers are already trained and available to assist underserved women in the public health setting to diagnostic resolution of their abnormal cervical cytology finding. In order for them to provide navigation services to the patient cohort, the patients must be referred to them by the nursing staff. By educating the ADPH staff on the program's goals and objectives, while expanding their availability to all county health departments, increased utilization of this program could be achieved, and patient navigation efforts could potentially become a standard of care. These are the 13 counties in which the 2 social workers currently serve for the Title X Community Health Care Coordination Program. A 3rd social work position has been created in order to expand care coordination to additional counties. This program started around the same time that I began my QI project in 2018, and it has since evolved. I've personally seen more of what the social workers can do as far as care coordination over the past couple of years. And I think that it's a very, very good program. I think that we just need to utilize them more and utilize them more on the front end of things to help the nurses also with the follow-up, because they are also, from what I understand, they are making sure they're also calling our patients and making sure that they are getting to their colposcopy appointment. They weren't doing that when I first started this project, but we need to utilize the resources that we already have. And the Title X Care Coordination Program includes 7 additional counties: Hill, Marengo, Wilcox, Pike, Russell, Chambers, and Randolph. In conclusion, adherence to recommended follow-up was improved in the patient cohort following evidence-based patient navigation. By utilizing a team approach, patient navigation programs in the public health setting have the potential to improve cervical disease outcomes, reduce the incidence and mortality rates of cervical cancer, and reduce costs associated with treatment. By conducting this QI project with the addition of a patient navigator into the current abnormal pap smear follow-up process, there is potential to support policy requirements of the National Breast and Cervical Early Detection Program and really just raise awareness of the Community Health Advisor Program while meeting objectives of the ADPH Strategic Plan for 2019-2023, such as improving health outcomes. If anyone has any questions, you can feel free to email me, or I think there may be a Q&A session after this presentation. And I would like to thank all of you for listening. Thanks you for your attention, and I hope you all have a great day.
If there are any questions, we certainly appreciate Ginger's presentation. So proud of her accomplishment, and we certainly are wanting to congratulate her, I would like to say while we're waiting on questions at this point that this concludes our program for today, and I certainly want to thank both Dr. Farr and Ginger for their presentations. If you think of questions, because they were both very intriguing presentations, you can send them in and we will answer those. While we're making sure there's no questions though, I would like to take this opportunity to present to Ginger a certificate of recognition, and I would like to read this for all to hopefully see. I'll just read though. This is presented to Ginger Phillips, D&P, on April 16th, 2021 at the 16th Annual Alabama Department of Public Health Nurse Practitioner Conference in honor of your achievements to your Doctorate of Nursing Practice, which exemplifies your contribution to professional development and exhibits your personal commitment to provide exceptional care for the women of Alabama. Ginger, we are so very proud of you, and we certainly it just sort of ties together to me the complete program with your doctoral project, and just want to thank you again for presenting that today. And we look forward to the growth of colposcopy and the ability to get our patients to next steps of care. That's what it's all about. Still don't see any questions, but I want, usually when we meet in person, we always have some gifts. So I want to let you all know that you will be receiving the electronic version of the newest edition, which will be the 21st edition of contraceptive technology. We've used it for many years throughout our program, and this will actually become an electronic version you have on your desktop. You'll be receiving a link and instructions on how to use that. And unfortunately, you know, we don't get to meet together this year, but we still wanted to give you a gift for all the things that you do. I hope that you each know that you can reach out to me at any point that you might need me, and the nurse practitioner seniors as well, and Dr. Thomas as well. We thank you for your service. You do make a difference, and we just appreciate what you do every day for patient care. I think this concludes our program. I don't see any questions at this time.